Okay, now coming into the second topic, the lead systems. One of the most confusing and one of the most feared topics of reading ECG. Now, most of us, when we start seeing these videos, we are start trying to read ECGs. This leads. What is this 1, 2, 3? What is this V1, V2, V3? Why? I mean, this is one of the most confusing part of ECG. I mean, I will try to make it as simple as possible. This will be a simplified form. It won't be very detailed. Don't worry. It will be to the point and simplified. Okay. So first thing, why is it important? Why should you know the lead system? First thing I would say is to the calculate the axis calculation. Second one is to know the position of the heart, whether the heart is either vertical, heart is the horizontal or the normal intermediate positions, like what is the position of the heart, that you can know. The axis, it is either left axis deviation, right axis deviation, northwest axis, all these things we can make out of it. And especially the CAD. Now what MI? What is the is it an anterolateral wall MI? It is an inferior wall MI, or it is a posterior wall MI. All this localization, this lead system forms the basic. Sorry. What is a electrode? That you should know. Electrode, we all know, when we put an ECG, we put one on the right hand, one over the left hand, one over the both the feet, and then we attach over the chest. Those things, the physical objects that you attach over this body, they are called as electrodes. What is it? It's an instrument which measures the electrical activity. Instrument which measures the electrical activity. That is what is called as the electrodes. Then what is an axis? Or what is a lead? Lead is actually an imaginary line. It's not an physical object. It's an imaginary line along which you measure the electrical activity. So along which you measure electrical activity. I will name out the leads. There are three limb leads: lead 1, lead 2, and lead 3. And then there are three augmented leads: AVL, AVR, and AVF. And there are 6 chest leads: V1, V2, V3, V4, V5, and V6. And few additional special leads: the posterior V7, V8, and V9, V7, V8, and V9, and RV leads. These are all the type of leads we measure. So these are all an imaginary lines, usually between a positive electrode and a negative electrode. And there will be positive electrode, there will be negative electrode, and then we measure the potential difference, between the positive and negative electrode. Thereby we measure that potential difference in the along the line, imaginary line. That is what is called as the lead system. Okay. Then now the next concept comes. What is a bipolar lead and what is a unipolar? So literally it is very simple. Bipolar means there are two different parts in your body. You measure the electrical activity along the two different parts. In a bipolar lead, two different parts or two different locations. Sorry for that. Two different locations we hear the bipolar leads, and unipolar at one location. At one location, we used to measure the leads. This is the difference between unipolar and bipolar. So along the limb leads, we will start with the lead ones. So there are three limb leads: lead 1, and 2, and 3. So imagine this is the human body. You say this is the right arm. This is the left arm, and this is the left foot. So there has to be the foot is all positive and the right arm is all negative, and this left arm is positive and this is negative. So imagine this diagram. Imagine a guy, someone whose face is this, and think this is hand and leg and this thing. Okay. Sorry for my diagram, I'm not so good at it. And the first thing you have to know is what is lead 1. Lead 1 is measured, is a horizontal lead. This is the horizontal lead. Start from between the right arm and the left arm. Between the right arm and the left arm, it is a horizontal lead. The left arm acts as a positive electrode, the right arm acts as a negative electrode, and the direction is from the right arm to the left arm. This is the lead 1. So we measure the electrical activity along this line. This is the lead 1. The second thing you have to know is what is the lead 2. Lead 2 is between the left foot and right arm. So lead foot, the right arm acts as the negative electrode and the left foot acts as a positive electrode. So the direction is inferior and towards the left. So this forms the lead 2. So the positive electrode is the left foot, the negative electrode is the right arm, and the direction of the vector is from the right arm. It goes inferiorly and towards the left foot. This is the direction of the vector. Okay. Now the lead 3. Lead 3 is between the left foot and the left arm. The direction is again from the, it is also inferior direction. Lead 3. This is also inferior. It is from the left arm to the left foot. The left arm acts as the negative electrode and left foot acts as a positive electrode. So lead 1 measures the potential difference between the both arms, between the right arm and the between the right arm and left arm, and it is the horizontal lead. And lead 3 is between the left arm and the left foot, left arm and left foot, and lead 2 is between the right arm and the left foot. So this is the direction, and which is the positive and which is the negative we have known. Okay, now we are going into the unipolar leads. Now before going into that unipolar leads, you have to know what is the augmentation. I already told leads AVF, AVL and AVR. They are all augmented unipolar limb leads. So this your augmentation literally means increasing the amplitude. That is what is augmentation. So unipolar limb leads, as I mentioned earlier, will measure only from that particular area. So consider these 3. This is the AVR. It measures electrical potential over the right shoulder, and AVL over the left shoulder, and AVF here. It measures only potential difference. And these 3, all the 3 are considered as positive electrodes. And we have an imaginary central line, a negative, that is called as a Wilson's terminal. This is an imaginary negative central terminal, and from consider the direction is from that side. So it goes from here, negative electrodes towards the positive electrodes. So AVR, the positive electrode is right arm, and negative is the Wilson's electrode. AVF, the positive is the this thing, and negative is the Wilson's terminal. AVL, this is the positive, and this is the negative. So why you need augmentation? The unipolar limb leads measure only the local electrical activity. Since this AVR is far away from the center, so the heart is here, heart is here, and this is measures electrical activity here. So we have this electrical activity will be very small, so the wave will also be very small. So to increase the wave, what we do is that for AVR lead measurement, we disconnect this arm. The right arm gets disconnected. Right arm is disconnected. So the right arm is disconnected. So the potential difference between the AVL and AVF and the central terminal is what is measured. So that gives rise the AVR term. And for AVL, same thing. The same arm, the left arm is disconnected, and AVF, the same thing is disconnected, same way. AVL, AVR and AVF. AVF, the left foot is disconnected. So this way we augment the these things. So then we have to know what is the different waves, like chest. We will go into the chest leads. So chest leads, as I mentioned earlier, they are unipolar leads. They do not require augmentation because they are very close to the heart. The augmented leads require augmentation because they are far away from the heart. The unipolar limb leads are close to the heart. So no augmentation is required. So this is the concept. So now we have to know the location. This is very important. I mean, you will only know the locations when you start putting the, connecting. Don't let the staff nurse or the ECG technicians to take ECG. You go there and start attaching. This should be in the right fourth intercostal space. This is the V1, and V2 should be in the left fourth intercostal space. Okay. Then V3 should be, V4 should be in the mid clavicular line. Left fifth intercostal space in the mid clavicular line. Okay, that should be the V4 up, and V3 is between the V4 and V3. You should place the V3 lead. Then anterior axillary line, you should have V5 and the same left fifth intercostal space in the anterior axillary line. Then V6 in the mid axillary line. Okay. V5 in the anterior axillary line and V6 in the mid axillary line. Okay, so V1 in the left fourth intercostal space, and then V2 should be in the right fourth intercostal. Sorry, this is right and this is left, and then V3 between V2 and V4, and V4 should be in the left fifth intercostal space in the mid clavicular line, and V5 in the anterior axillary line, same left fifth intercostal space, and V6 should be in the mid axillary line. If you place V7 should be in the posterior axillary line, and V8 should be in the mid scapular line. So it will go posteriorly. The leads will start placing posteriorly. So when will you place this posterior leads? This is a clinical point. When you have an inferior wall MI, and if there is a suspicion of an RCA infarction, then you have to do a posterior. It's better in any inferior wall MI, you do a posterior leads, just to rule out the posterior wall MIs. And any patient with the ST depression in V1, V2, V3, don't think this as just an STEMI. This can be a posterior wall MI. So any inferior wall MI or any patient with an ST depression in V1, V2, V3, do a posterior leads. This is a clinical point. I think throughout this sessions I will add some clinical points, then and that, rather than it being a pure theory session. I think we can add some extra points there. Okay. Now we have identified what is the different leads and where it is placed, and right-sided leads. Right-sided leads will be placed similar to this. The right-sided in the same thing in the right side we will start placing. Right, fifth intercostal space, in the same way you have to place it. Okay, so importance of lead AVR. AVR is always a completely negative lead. So the P wave will be used to be negative and the QRS should be negative. If it is positive, then we have to think there is something abnormal in that ECG. So this is not always positive. So the location. And if you think this is the interventricular septum, this is the RV, and this is the LV. The V1 measures activity over the interventricular or the RV side. V1 is RV. V1 measures the activity over the right ventricle. The V2, V3 and V4 measures the activity over the interventricular septum and the LV, anterior, the LV sinus frenda, and V2, V3 and V4. Then V5, V6 measures activity over the lateral wall. V5, V6 over the lateral wall. And 2, 3 AVF measures activity over the inferior wall. So, and 1 AVL also gives high lateral wall. This is very important. This is very, very important. I would say you start reading ECG in this CAD territories. You start because 1 AVL indicates high lateral wall, 2, 3 AVF. This indicates inferior wall, V5, V6 indicates lateral wall, V1 indicates RV changes, and V2 to V4 indicates the LV or this thing, interventricular septum and the LV anterior wall. So you have to start seeing ECG in this territory. You start from ECG, you start reading from 1 AVL, V5, V6. You know this is a lateral wall MI, this is the LCX territories. Then you have to look at 2, 3 AVF. This is the inferior wall at the RCA territory. There's definitely overlap, but this is a simplified version. Then look at V1. V1 is the RV part. Then you look at V2 to V4. This is the LAD territory. Then you come and look at the AVR. AVR, any positivity is there. This is a no man's land. So AVR will be positive when there is an LM stenosis, LMC occlusions. AVR can raise and all the other things can go down. So this is a in short representation of the limb leads.